Yay.
And we need the slides.
Yes, I'll put them right back up.
Well, good morning and hello, everyone. Welcome to our May GIC meeting. I want to welcome all of our viewers on YouTube to today's meeting. And I'm really excited to get into this content and the topics that we have for today. I am Valerie Sullivan. I am chair. And today we are joined by our group of commissioners. And a new commissioner has joined. Her name is Kristen Pepin. She is going to be a new commissioner, and we welcome her. She is joining us for Liz Shabbat's position. Some of you may have seen that Liz was not with us last week. She has recently retired from trial court. It's been great to get to know Liz and have her on our board. So we wish her well in retirement. Liz, we wish you were here in person for us to provide you our well wishes. But at this point, Kristen, if you want to say a quick hello to everybody, we're really excited to have you join.
Hi, my name's Kristen Pepin. I am basically the new Liz Shabbat. I took over her position as the president of Local 229 Union. I'm a probation officer for 25 years, state employee for DCF for 6 years prior to that. So well versed in the state system, and I am very happy to be here.
Well, thank you. I think we all wish you well. So at this point, let me turn this over to Andrew to let all of you know other commissioners who are joining us today for this board meeting. Hello, Andrew.
Good morning. In addition to our new Commissioner Pepin and Chair Sullivan, we are joined today by Dana Sullivan, who is the designee for Administration and Finance, Rebecca Butler, who is the designee for Department of Insurance, Commissioner Toby Choate, Commissioner Tamara Davis, Commissioner Jane Edmonds, Commissioner Giusino Garand, Commissioner Eileen McEnany, Commissioner Melissa Murphy Rodriguez, Commissioner Jason Silva, Commissioner Anna Sinenko, Commissioner Timothy Sullivan, and Commissioner Catherine West.
We have almost a full house here today. That's great. Nice to see everyone. So at this point, let me turn the agenda over to Matt so that he can review our meaty agenda for today's meeting. Hello, Matt.
Hello, Madam Chair. Welcome, members of the commission, members of the public. Commissioner Pepin, welcome to the crew here. I look forward to working with you. And so for today's agenda, it may not look meaty, but it's actually rather meaty. In our executive director's report, I will spend a fair amount of time on a few notable items. So having only one other major agenda item is helpful in that regard. We will then hand it over to Lauren Makashima, our data analytics manager, to walk through a rework of our out-of-pocket report. We've gotten excellent feedback from the commission in the past, and I'm excited to present you the results of our thinking through that feedback. Other than that, that's the agenda.
All right. Well, we look forward to a executive director's report because there is a lot going on. But before we jump into the agenda, can I have a motion to approve our minutes from our last meeting in April?
Motion to approve.
Second. So Toby and Jane, thank you. So at this point, I, and Andrew, you're going to take a roll call. So thank you.
Thank you. Commissioner Designee Sullivan.
Aye.
Designee Butler.
Aye.
Commissioner Choate.
Approved.
Commissioner Davis.
Aye.
Commissioner Edmonds.
Aye.
Commissioner Garand.
Aye.
Thank you. Commissioner McEnany. I'll come back. She's stuck in traffic. Commissioner Murphy Rodriguez.
Aye,
Oh,
sorry.
sorry. It's all right. Okay. Commissioner Murphy Rodriguez.
Yes.
Commissioner Peppin.
Aye.
Commissioner Silva.
Yes.
Commissioner Sinenko.
Aye.
Commissioner Sullivan.
Yes.
And Commissioner West.
Yes.
Motion passes unanimously.
All right, great. Thank you. So let's get into your executive director's report, Matt.
Terrific. Thank you, Madam Chair. So I'll start with a brief human resources update, just because we have a fair amount happening in that space. I'll start. So we have 3 new hires that I want to bring to your attention. Emily and I have been working very closely with Brock Weidenheimer, our extraordinary HR director, to fill a number of positions. This last month, we welcomed Morgan Simcoe as our new government affairs manager. Morgan has an excellent resume, including time working in the legislature, has a real interest in public health matters and a master's degree in public health. Happy to have her on board. Welcome, Morgan. We also recently welcomed Dan Gumble in the role of counsel in the legal department, reporting up to Andrew Stern, our general counsel. Dan will support a broad range of legal programs, including serving as the Records Access Officer, the RAO, supporting compliance with a variety of state and federal laws, and conducting legal research in a number of important areas for us. So welcome, Dan. Happy to have a fully staffed legal department. Lastly, we are looking forward to welcoming Jiangsu Li as a full-time member of our data analytics team. He'll have the title of healthcare analyst, reporting to Lauren Makishima. Jiangsu has been interning with the data analytics team since 2024 while attending the Harvard Chan School of Public Health. And we were so impressed with the depth of his skills that we created a new position so that we could retain him beyond his internship. Joining the data analytics team, this is something that I have been keen to do for a while, is to add some additional bandwidth to our analytics team, and we're just excited to have his talents help us to understand data and use it to inform our strategic decisions. So welcome, Jiangsu. We are also in the interview phase, moving quickly to the interview phase for CFO to backfill since we've lost Jim Rust, so working actively on that. I will pause before moving on to other items if there are any questions on human resources.
Matt, Toby, how does the hiring freeze affect you?
So the hiring freeze just announced yesterday, mid-morning, by the state. It is a hiring freeze. So, as we have additional vacancies going forward, we will have to navigate that. I'd say for the CFO, which is of course a critical role for us, we are already well into that process, so it will not affect us. But as we have additional departures or retirements from the team, we may end up in a position where we're unable to fill a vacant role. But we will, of course, as we always do, advocate vigorously to make sure that we are fully staffed. We're a small staff, as you all, I think, can appreciate. So even the loss of one person can be impactful. So we're planning for it. But at the moment, I'm feeling good about how we can navigate it.
Thank you.
Yep.
That's good news. I don't see any other questions. Good question, Toby. Thanks for bringing that up. It's all on our minds for sure. So what's your anticipated hire date, Matt, for the CFO, given, potentially there's a need to accelerate it, so this hiring freeze doesn't somehow have an impact?
Yeah, I don't anticipate it will. And I would certainly by the end of the fiscal year, we hope to have a CFO on board.
Okay, great, thanks.
You
All
bet.
right, let's keep moving.
All right, so the second item, which I'm sure you all are somewhat aware of just from reading media reports, we have, so I want to discuss our supplemental budget funding request. So as we have been reporting to you over the last few commission meetings, I think going back to January, we've been experiencing a higher than projected spend on medical and pharmacy claims, which has left us significantly short this year of our appropriation with about 7 weeks remaining in the fiscal year. As we always do, we've been working very closely with our partners across state government, including at Administration and Finance, to address this projected shortfall and with the hopes of avoiding any disruption for our members. As we have noted in prior meetings, we are running unfavorable to budget due to a number of reasons, but including the rising cost and utilization of GLP-1 drugs. We have projected and said to the commission prior that should claims continue to outpace our appropriation, we would need supplemental funding to cover the shortfall by no later than May the 12th, which was this past Monday. Through the end of April, we continue to average a monthly deficit of about $20 million and a year-to-date deficit, I think through April, that is pegged at 188 million, so about 8.1%. But at this point, we do still project a deficiency of roughly 240 million before the end of the fiscal, which is what we've reported to you in prior meetings. So just a couple of words about this. So while we have not experienced a budget variance of this size in quite some time, historically speaking, this is not unusual. It's a feature of being a self-insured purchaser, and there are mechanisms in place to accommodate this sort of claims experience. Just as the Commonwealth receives a reversion to the general fund when our claims come in lower than projected, the Commonwealth likewise bears the risk when claims come in higher than initially projected. So this is all by design and not unusual. So with our claims running higher, the governor filed a supplemental budget request in early April, for which we are thankful, and with the anticipation that that would avoid any potential disruption. However, by late last week, when it became clear that the supplemental funding wouldn't pass and be enacted by the May 12th date, we had to initiate a contingency plan. And the contingency plan that we put in place really is focused on avoiding any disruption to our members and to providers, or at least mitigate that to the degree that we could. So the step that we took was to pend or hold medical claims for payment until funding was in place. So I do not have the statutory authority to spend funds until a supplemental bill is passed. This action did not apply to pharmacy claims, which have continued to be paid promptly. So on Friday of last week, we and our carriers informed providers that they should, number one, continue to serve GIC members and to continue submitting claims as usual. They were further advised that claims would not be denied, but rather delayed until the supplemental budget was passed, which we expected would happen in short order. Of course, taking these steps, we don't take lightly. We understand that they can cause some anxiety, but it was the only decision essentially that we had at our disposal to preserve our members' coverage, to preserve their access to healthcare services and medications while we wait for the supplemental funding. So on Monday, this past Monday, the 12th, we were thankful that the House advanced our supplemental budget request and moved it to the Senate. And I'm happy to say that the Senate is slated to take that up later this afternoon, and I would expect it would be promptly signed by the governor. So when that happens, we will be able to lift the hold on claims and promptly process those claims for payment. So despite the anxiety that this has produced in some corners, at the end of the day, it's very likely to work out, actually at the end of today, likely to work out so that we will not miss a payment cycle for our carriers. As you can imagine, the last week has been very busy for us, and we've, as we've managed through this, we've taken every step to reassure our members that it would not impact their access to care. We've had outbound communications through our GIC coordinators. We've posted information on our website. We've communicated with our labor unions and representatives of our retirees, stayed in close touch with them. So as this moves towards resolution, we will continue to keep you all updated and again, use all of those communications channels to make sure that our members and providers understand what the implications are and to essentially ease any concern that folks may have. So that's a lot, but I thought it would be helpful to kind of give some context to this. And I'm happy to take questions that commissioners may have.
Yeah, well, thank you, Matt. You have been very prompt and efficient in keeping all of us on the board focused on this initiative. I know last meeting, you let us know that this supplemental budget had been filed. You do a very good job of keeping us posted. So we do appreciate that. And we are confident, or at least we're grateful that the governor has filed this budget and the request, and we're hopeful it will be completed and approved today by both the House and Senate. So I see Eileen has her hand up. Eileen?
Yes, good morning. Thanks. So Matt, I did have two questions if I could. One, how come pharmaceuticals continue to get paid? Like, how is their payment different? And then kind of more an observation question, but every meeting I marvel when Jim would make his presentation about how closely we tracked to the actual estimate, right? It's usually right on the money. And I guess the question is, to avoid having to go through the supplemental budget request, do we not be as precise? Do we build in a little cushion so that we avoid having to do this in the future?
Yeah. So to your first question about prescription drugs, I think I would want to call on Andrew and or Emily, who've been working hard on this as to how we ended up with that decision. I would say, pharmacy claims happen much more quickly. The adjudication of pharmacy claims through our PBM happen much more quickly than medical claims, for which there's typically a pretty substantial lag. And so our concern was that, that being the case, we wanted to avoid the possibility that someone would show up at a pharmacy to get their prescription and be told that they would not have access to that prescription. So it really was with an eye towards continuity of access to important medications for our members that we feared would be disrupted if we didn't take that step. Emily, Andrew, anything you would add to that?
No, you pretty much nailed it. They adjudicate almost instantly. The pharmacy claims. It's a much more seamless process than medical claims. And our budget director was watching to make sure that there was money allocated, that what was left in the budget could go towards the pharmacy claims.
All right, that's good attention to detail. So thanks for that.
So on your second question, Eileen, it's a good question, and I think it would likely lead us to be, look, we're heading into a very unusual, challenging time as it relates to pharmacy trends. We've talked about this a great deal this year. So it's more turbulent, and in setting premiums, you have to account for turbulence and uncertainty. I'm happy to say that as we've been developing the FY26 budget, which is now before the legislature, Senate will take it up next week, that we've been able to accommodate those more recent trends in those projections. So I do see this as primarily an FY25 challenge to get us to the finish line. But I think the challenge is always going to be that there's this time lag, right? So when we set our premium rates for FY25, we did so last March. And that was at a time when GLP-1 drugs, for instance, the trend was relatively flat. There were some constraints in the manufacturing of those drugs that kept that spend relatively low. But then immediately subsequent to our decision on premiums, there was a sharp spike, which you'll see illustrated in some of the slides that Lauren has for us. So it's a challenge and feature of the extended timeline. We're not unique in that regard. As you well know, Eileen, the Division of Insurance working with the carriers is similarly challenged by essentially having to project 7 months in advance of a year what the spending is going to be when the process begins. So it's a challenge. But you're right that a good actuary developing rates in an uncertain time would accommodate that uncertainty in the premium development process.
Thank you.
You're welcome.
Matt, could I follow on with a question to that? So are you saying that the budget that's currently before the legislature, assuming it maintains intact, encompasses the significant increase we experienced this year in claims, plus some type of buffer? Or what are you saying?
How would I describe it? I would say the budget as it's before the legislature submitted by the governor, we anticipate would be sufficient based on what we know today to cover our claims costs for the coming year.
Okay, so if the rates, does it assume any increase in the claims?
It does. It does. So for instance, the rates that we brought to you in March, I guess this year was at the end of February, early March, we then had a much longer period of claims experience on GLP-1s, on provider medical costs, that we were able to accommodate that we just weren't able to accommodate for last year. Now, that said, it's an uncertain time, and there's a lot of volatility. So it's hard to predict how the coming year will shake out, but we're feeling confident with what we know now that we have sufficient allocated dollars for next year.
The reason I asked the question, when I first joined the GIC, which was many years ago, this was an annual event. Because the deficits were so huge, they didn't fund the budgets, and they just kicked the can down the road till after the end of the fiscal year, and then there was a supplemental process. It was a mess.
Yeah, I wouldn't describe the way the budget has developed this year in the same way. I'd say the projections that we've had have been baked into the budget in a responsible way.
Yeah, no, I wasn't insinuating anything else. It's just, that things happen that you can't control in many ways. So
Indeed.
yeah.
Oh, thanks, Toby. I see Anna has her question, comment. Go ahead, Anna.
Yeah, thanks. I was just curious. I mean, I think we're all reading a lot about GLP-1s, across the board and understand very much how expensive those are and the growth in prescribing. And I just wondered if you guys have been able to do an analysis to understand how much of the over budget is from those prescriptions versus, increased hospitalizations or other high price medical services. Because I would be interested, and I think we all would be interested in knowing just what is driving that over budget. Because I would think maybe some of it was GLP-1s, but not all of it. But that's just my hypothesis.
No, I think that's right. The increased use of GLP-1s, again, as you'll see in the slide, a slide in Lauren's presentation, is a material part of this increase. But it's not the only reason for the increase. We have, of course, we've talked a lot about the really challenging environment in rate negotiations between our health plans and our providers. Those contracts typically have a January 1 effective date, but some of them also have a July 1 effective date. And again, so when we're setting our rates in March and determining our premium increases for March, there's aside from the GLP-1 projections, there are a set of assumptions about the unknowns about what those contracts will look like. And I would say that continues to be our primary challenge. And we see that again reflected in our year-end budget variance. Does that answer your question?
Yeah, thanks. I'm that answers it, and it's great to know that you guys are doing that level of analysis.
All right. Well, I don't see any other comments or questions. I appreciate all of the commissioners' input and attention on this very important topic to help support you, Matt. I think everyone's focus is on our members, making sure that they don't get left without the opportunity to do to focus on their healthcare. So thanks for keeping our members top of mind, Matt, and keep us posted.
Yep, we will do. And Anna provided an excellent segue into the last item in my executive director's report, which is a pharmacy update. So so our contracted pharmacy benefits managers, the CVS Caremark, recently announced its formulary updates for our plan on July 1, 2025. Actually, they're global formulary updates. They do this twice a year, and the update for July 1 will include a change related to the GLP-1 medications for weight loss. CVS has removed the drug Zepbound from coverage, while Wegovy and Saxenda will remain in place as preferred due to their negotiated lower unit costs. These are the types of changes that we rely on our PBM to initiate on our behalf. We want to be able to provide maximum value and savings on an important class of drugs, and this allows them to negotiate a favorable unit price. We are working very closely with CVS around their communications to our affected members and to prescribers. I will note that we confirmed with CVS that there will be an exception process in place, as there typically is in this sort of a situation, for those members who are currently prescribed Zepbound, who are not able, for whatever clinical reason, not able to take Wegovy. That process, that exemption process, will mirror that for other non-preferred drugs. However, the process cannot begin until the formulary change takes place on July 1st. So in the meantime, CVS has notified providers so that they can begin working with their patients on a transition here. So this comes at a time, as I'm sure all of commissioners will know, that a number of health plans and employer plan sponsors are dropping coverage for GLP-1s for weight loss altogether. This coverage landscape is changing very rapidly. Just yesterday, another carrier noted that they were dropping coverage for certain elements of their book of business. And while we do not have plans at this time to eliminate coverage for GLP-1s for weight loss, we are actively evaluating steps that we can take to strike the right balance between cost and access. And we expect to have more to report to you in the near future. This is a very dynamic space. We understand, let's say this finally, we understand that members may have concerns about this change. Some have already begun to reach out to CVS and to us with questions, and we are prepared, of course, to field those inquiries and provide the most up-to-date information as we receive it. So I'll pause there for questions, comments.
Yeah. I don't see questions, Matt, from our commissioners. I do think we are very focused on our members, and we also, have these budget constraints. So we appreciate that CVS Caremark is doing some work to try to mitigate these. So this is what we'll hear from upcoming with Lauren's presentation. And just wondering, once this product is off formulary and members who are taking it, there's an exception process. If they do get approved to stay on their unpreferred product, is there a difference in copay? What are some of the things that CVS Caremark is doing to try to save us some money and keep the preferred formulary moving forward?
I'd call on Andrew and perhaps others to chime in on that. I don't believe that we're making any changes to our plan design as it relates to these drugs. But Andrew, is there anything that you wanted to add that would be helpful here?
No, it would be handled just like any other exception process. It'd probably come in at the tier 3 copay.
Okay.
It is, by going through an exception process, it's covered through the formulary, but at the highest copay. Whereas if it wasn't on the formulary, then it's out of pocket, basically.
And those drugs, just because the cost is so high, the out of pocket can be also very high and untenable for our members. So let's just make sure we're looking from an attention to detail perspective on impact to members, no delays in therapy, and making sure that there's as much communication as possible. So we look forward to this initiative as potential cost savings, and also still supporting our members. So let's keep moving. Let's hear this presentation. We love data. So
excellent. Before we do that, just a quick look at our calendar, only because we've made a couple of changes since you last saw it. In June, as we had predicted, this is on schedule. We'll report out on our annual enrollment. Once we get all of that wrapped up, we can update the commission on trends that we've experienced this period. And you may also notice that we've moved the Life and LTD consultant vote from today's agenda to the June meeting, so that the procurement team can have a little more time to wrap that up. So we anticipate having a recommendation in June, and we'll also, as we typically do, bring trust fund authorization to the board for a vote.
yes, and this meeting on the 18th is on a Wednesday, because Thursday, June 19th is a holiday for June 19th, right? I know you said that, I'm just repeating that. It's Wednesday.
Yep. Yes, thank you for noting that.
All right, let's keep moving.
All right, so on to our out-of-pocket report. So as I mentioned at the outset, in response to commissioner feedback from prior reports, the analytics team has really kind of worked to rework our out-of-pocket report. What we're hoping to do here is to better contextualize our out-of-pocket spending with total medical and drug spending and highlight cost savings that we've achieved through the last procurement, even as costs do continue to climb in the marketplace. Broadly speaking, the GIC, as you'll see in this presentation, is in line with our peers in the jumbo group market. And you'll see how GIC plan design really continues to protect our members from major increases in out-of-pocket spending. So with that, I'm happy to turn it over to Lauren Makashima, our data analytics manager, to present this year's report.
Thank you so much, Matt. And good morning, commissioners. It's great to be with you this morning to present the fiscal year 2024 out-of-pocket report. My name is Lauren Makishima, for those of you I haven't met, and I'm the data analytics manager here at the GIC. Before we dive into the report, as Matt mentioned, there have been a few changes in response to commissioner feedback. Past reports have focused almost exclusively on member out-of-pocket cost metrics, but we know that out-of-pocket costs are a relatively small part of the total medical and prescription drug claim spending for GIC members. So it's the sum of the out-of-pocket costs and GIC paid costs that drive the premium trends. So it's helpful to view those two metrics together. This year's report aims to contextualize out-of-pocket trends by adding comparisons to the GIC paid amount trends for the same time periods so that we can determine the extent to which drivers of each trend were the same or different. And the second change to this report is to examine how changes from the last medical carrier and PBM procurement impacted out-of-pocket costs. Fiscal year 2024 was the first year of the new set of medical carrier and PBM contracts, and there were changes to the plan portfolio between fiscal 23 and fiscal 24 that caused member migration. So in order to understand the out-of-pocket trends, we need to first understand how those plan changes and member migration impacted out-of-pocket costs. I hope those changes will make the report more informative for commissioners, and we're always open to additional feedback on how we can best meet the commission's data needs. So we have three goals for this report. First, we'll take a look at the high-level out-of-pocket and GIC paid trends. Next, we'll examine how the procurement changes may have caused those metrics to increase or decrease, and we'll break GIC paid and out-of-pocket costs down to understand what spending areas drove those trends. And finally, we'll compare GIC members' out-of-pocket costs to Massachusetts benchmarks. Next slide, please. All right, so starting with our first objective, we'll take a look now at the high-level out-of-pocket trends and GIC paid trends over 3 fiscal years. Next slide. All right, so starting with Medicare members, we can see that out-of-pocket costs on a per member per month basis were very stable between fiscal 22 and fiscal 24. The yellow line here represents prescription drug out-of-pocket costs, and the purple line represents medical out-of-pocket costs. Between fiscal 23 and 24, total out-of-pocket costs increased 12 cents per member per month to $51.51 per member per month, with prescription drug costs increasing 25 cents PMPM and medical costs decreasing 13 cents PMPM. Medicare members typically have higher out-of-pocket costs for prescription drugs as opposed to medical services, which is the opposite of non-Medicare members, as we'll see on the next slide. Medicare members have no deductibles and no or low copays for most medical services, and Medicare members also utilize more prescription drug medications than non-Medicare members on average. Next slide, please. This is the same graph of out-of-pocket costs per member per month, but for the non-Medicare population. We can see that those lines are flipped, showing that non-Medicare members have higher out-of-pocket costs for medical services than for prescription drugs. As a quick refresher on the GIC's non-Medicare plan designs, all plans have medical deductibles of either $400 or $500 for the individual coverage tier and $800 or $1,000 for the family coverage tier. There is also a $100 deductible for prescription drugs. Once the deductible has been met, members pay a flat copay for most services, and the GIC covers the rest of the cost of the service or drug. Because GIC plans have mostly copay-based cost sharing, and because there haven't been any major changes to the cost sharing amounts, out-of-pocket costs were relatively stable over the 3-year time period. Between fiscal year 23 and 24, medical out-of-pocket costs increased 35 cents per member per month, while prescription drug out-of-pocket costs decreased $1.19 per member per month, totaling to an overall decrease of 85 cents PMPM. If we combine the FY24 medical and prescription drug costs, members spent $59.65 per member per month out of pocket. We'll take a closer look at the factors contributing to these trends as we move throughout the report. Next slide, please. Okay, so the left set of lines in this graph is the same member out-of-pocket graph that we looked at on the previous slide, but now we've put those lines side by side with the GIC paid amounts per member per month on the right side. So we can see that between fiscal 23 and 24, GIC paid increased $35 PMPM or 6.4% for medical services and $12 PMPM or 5.9% for prescription drugs. I'll note here that the GIC paid amounts for prescription drugs in this report do not reflect the impact of prescription drug rebates, which would have the effect of lowering the yellow line in this graph. So comparing the left and right graphs, we see how GIC's copay-based plan designs have kept member out-of-pocket costs stable and protected members from incurring unexpected out-of-pocket costs as the GIC has absorbed the impact of rising costs. In later slides, we'll break this $35 medical increase and $12 prescription drug increase in GIC paid PMPM down into its components to understand the drivers. Next slide, please. Okay, so before we break those trends down, though, I'd like to spend a few slides discussing the impact of the procurement changes so that we understand the context for these trends. Next slide, thank you. This is the recommendation slide from the last procurement, and the numbered bullets here show the changes that took effect in fiscal 24. So first, Harvard Pilgrim's Access America plan became the new plan offering for members living outside of New England. Previously, those members were enrolled in WellPoint Basic, formerly known as Unicare Basic. And in fiscal year 24, the WellPoint Basic plan became WellPoint Total Choice, and enrollment was restricted to members living either in New England or overseas. At the same time, the .32 merger between Harvard Pilgrim and Tufts had just happened. So beginning in FY24, Tufts plans were no longer offered to non-Medicare members, and members who didn't shop for a new plan were defaulted into the corresponding Harvard Pilgrim plan. And finally, the Mass General Brigham Health Plan Complete HMO transitioned from being a regional plan only available in Eastern Massachusetts to a broad plan available across the state. Plan design for the Complete HMO was updated to align with the other broad plan benefit designs, meaning that copay tiering was added for office visits and inpatient stays. Next slide, please. Okay, so now we'll take a look at how the membership shifted in response to these product offering changes. This slide shows average monthly membership by fiscal year for each of the broad network plans. The color of the bar indicates the carrier. Starting from the left-hand side, the purple and dark blue bar shows combined fiscal 23 enrollment for Tufts Navigator and Harvard Pilgrim Independence. These members shopped for or were defaulted into the Harvard Pilgrim Explorer plan in FY24, which is the all purple bar. While most members transitioned from one of those two plans into Explorer, you can see that the FY24 bar is shorter than the combined FY23 bar, meaning that roughly 15,000 members chose to move into a different plan. Looking at the second set of bars, WellPoint Plus gained about 10,000 members in FY24, primarily from the discontinued Tufts Navigator plan. And if we look at the yellow bars on the right-hand side, MGB Health Plan membership also increased by about 3,000 members as the plan became available across the state. And the majority of that increase was also made up of former Tufts Navigator members. Next slide, please. Finally, if we look at the remaining blue bars for WellPoint Basic and Total Choice, most basic members in New England or abroad moved into the Total Choice plan, and about 4,000 members living outside of New England enrolled in the new Harvard Pilgrim Access America plan. While this change may seem very small, the GIC actually recognized material savings from this switch. Next slide, please. This graph shows what the GIC paid for medical care for the roughly 3,400 members who were previously enrolled in BASIC in FY23 and switched into Access America in FY24. GIC paid costs for these members decreased by $12 million in fiscal 24, with almost all of the savings coming from members residing in Florida. So what this tells us is that the Access America rates for Florida providers are much more favorable than the basic provider rates were, and that by switching the plan offering to the Access America plan, the GIC was able to reduce costs without increasing member out-of-pocket costs or reducing benefits. The $12 million in savings actually exceeds the $9 million we were projected to save at the time of the procurement vote, and members who switched into the Access America plan were also able to reduce their premium costs by about 20%. So this change was really a win-win for members in the GIC. Next slide, please. The last plan change we'll look at is the MGB Health Plan Complete HMO. Enrollments increased as the plan became available across the state and as members switched into the MGB plan, mostly from the discontinued Tufts Navigator plan. Next slide, please. Okay, and here's a closer look at the copay changes associated with that change from the regional to broad plan classification. You can see here that PCP office visits went from a flat $20 copay to a tiered $10, $20, or $40 copay, and a third copay tier was added for specialist visits at $75. And in the bottom row there, you can see that the copays for a hospital admission went from one tier at $275 to three tiers at $275, $500, or $1,500 per admission. These changes bring the MGB Health Plan Complete HMO plan design in line with the other broad network plans. While the MGB plan is an HMO, MGB members do have access to a broad range of providers, including some of the providers with the highest relative costs. So same as the other broad plans, these copay tiers encourage members to select high-value providers. The overall impact of this change is, as you would expect, an increase in member out-of-pocket costs for the MGB Complete plan. Next slide, please. Finally, I wanted to also note that fiscal 24 was the first year of the new PBM contract where non-Medicare prescription drug benefits switched from being administered by Express Scripts to CVS Caremark. We did not change the plan design or any cost-sharing amounts as part of this switch. And CVS was already the incumbent PBM for the Medicare plans. Next slide, please.
Savings for that.
So with all of that context in mind, we can now come back to this graph and explore some of the drivers of trends. Keep in mind that all of the member migration that we just looked at on the previous slides makes interpreting the medical trends a bit tricky. For example, if a member switched medical carriers between fiscal 23 and 24, their new carrier may have higher provider prices for one type of service, but lower prices for another type of service compared to their old carrier. In other words, the membership basis for our per member per month metrics has shifted a bit, and the impact of those shifts will vary depending on the type of service that you're looking at. So we don't want to read too deeply into the one-year trend for any one particular service category this year, but we can still observe some general patterns if we break these increases down by type of service. On the next couple of slides, we'll dig into each of the trends shown in the bubbles here. First, we'll take a look at the components of the 35-cent increase in medical out-of-pocket PMPM and the $1.19 decrease for prescription drug out-of-pocket PMPM. And then we'll do the same breakdown for the GIC paid metrics. Next slide, please. Okay, so this graph shows the top 5 medical cost drivers of out-of-pocket spending in the left-hand set of bars and the prescription drug drivers of out-of-pocket spending by specialty, brand, preventive, and generic drug categories on the right-hand side. The green bars here indicate increases in out-of-pocket PMPM between fiscal 23 and 24, and the blue bars represent decreases. Those bars sum to the gray subtotal bars to the right of each set of bars and to the grand total bar on the far right. Starting with the medical side, we can see that there were small out-of-pocket increases for outpatient surgeries, physician office visits, and outpatient psychiatric services, and then there were decreases for lab tests and office surgeries. The increases in outpatient surgery and outpatient psychiatric out-of-pocket costs are due to a fiscal 24 change to align copays for WellPoint plans with the other non-Medicare plans. The increase in professional office visit costs is partially due to the addition of copay tiers to the MGB health plan benefit design, as we discussed previously, and partially due to a small uptick in utilization. Lab tests showed a decrease in utilization, while it was the out-of-pocket unit cost that decreased for physician office surgeries. The changes in out-of-pocket costs for all of the other categories essentially canceled out to a net 2-cent increase. Altogether, medical out-of-pocket PMPM increased by 35 cents. On the prescription drug side, there were some small increases for specialty and brand drugs, but the real trend driver for fiscal 24 out-of-pocket costs was that blue bar for generic prescription drugs. Out-of-pocket costs decreased $1.39 PMPM for generic drugs. This was primarily due to the PBM change. CVS Caremark seems to have lower allowed amounts than Express Scripts for several generic maintenance medications used to treat common conditions such as hypothyroidism, asthma, depression, and hypertension. Just as one example, levothyroxine is a commonly prescribed generic medication for hypothyroidism, and over 60,000 scripts are filled for this drug per year among GIC members. Express Scripts had an allowed amount of about $24 per script for this drug, while CVS's allowed amount is about $4 per script. As you can see from this graph, members benefit directly from these savings, and some members who are only on 1 or 2 generic medications may not even hit the $100 prescription drug deductible within the plan year anymore. On the next slide, we'll do the same breakdown for the GIC paid trend. Okay, so here's that same graph, but this time we're breaking down the $35 PMPM increase for medical GIC paid and the $12 PMPM increase for prescription drugs. On the medical side, the top 5 cost drivers were increases in outpatient surgeries, medical inpatient stays, outpatient pharmacy, outpatient psychiatric, and surgical inpatient stays. Compared to the previous slide, the all other medical category is the largest of the medical bars at $12.39 PMPM, suggesting that the increases were spread across many categories rather than being concentrated in 1 or 2 categories that drove the trend. Again, we don't want to read too much into any one single category here because this is just a 1-year trend and because of the member migration, but it's safe to say that GIC paid costs are rising across many service categories on the medical side. Next, for prescription drugs, it's probably no surprise that GLP-1 agonist drugs were a major cost driver in fiscal 24. We saw a large $15 PMPM increase for the brand drug category. Again, that's gross of rebates. And the weight loss and diabetes therapeutic classes that include GLP-1s account for about 3/4 of that increase. We'll take a closer look at GLP-1 trends in a moment, but before I move on, I also want to highlight the $1.43 PMPM decrease in GIC paid for specialty drugs, which may be somewhat surprising considering that increasing specialty drug costs are typically a cost driver. The main reason for this decrease has to do with Humira, which is a biologic injectable medication used to treat rheumatoid arthritis and several other inflammatory conditions. In April 2024, CVS removed Humira from the formulary and began preferring adalimumab biosimilars such as Hyrimoz. This data actually only goes through the end of June 2024, so we're only seeing 3 months of savings from that change in this graph, but it was actually enough to drive savings for the whole specialty class negative in fiscal 24. And just to be clear, this is still just a 1-year trend, and costs for the specialty drug category are still very high as new and expensive drugs come onto the market. But the main takeaway here is that biosimilars offer a lot of promise for cost savings potential, and the GIC and CVS teams are monitoring this space closely.
If I could just add one comment here. So when I look at this slide, Anna, I remember your question about, what were the contributing factors to our budget performance this year. And I think the trends that you see here are really the trends that once this year is complete and we're able to have a full picture, will be very similar. We see significant increases in utilization and price on the medical side. We see rising utilization, and given the price for GLP-1s, a significant uptick there. At the same time that we see, as Lauren noted, some significant value from the introduction of biosimilars, which of course we hope to see continue as more drugs move to generic or biosimilars.
Yeah, that's helpful. Thank you, Matt. Lauren, while the floor is open a little bit, I'm curious about oncology services. So it's surprising that the cost of oncology isn't captured here. Is it possible it's in inpatient medical and it's not sussed out to the same degree? Do you capture that data at all?
Sure. Yeah. So any spending for drugs administered in a facility would be captured within the respective categories on the medical side. The spending for those drugs would be captured within the all other medical piece here. That is still definitely a component of increasing spend, but here we're just looking at the top 5 categories.
Well, that's a really good point, Madam Chair, because if you look at the prescription drug side of the ledger here, that picture does not include a significant drug component that really, in our data, because they're administered in an inpatient or outpatient setting, not on the pharmacy benefit, really are captured in the left-hand side of the slide.
Yeah. I just wondered if inpatient medical at $5.09, what percent is that inpatient cancer therapy versus all others? Because, there has been data out there that, length of stay is shorter and shorter for traditional, pneumonias and other things. But is that not the case? And so what is driving up inpatient medical? And the same thing with inpatient surgical. Are these cancer surgeries, or are these traditional run-of-the-mill knee surgeries and hip surgeries, which again make people's lives better, but is it utilization, is it cost? You've always given us that information. It's a combination of both.
Mm-hmm. Yeah, and I'll ask Lauren to chime in on this, but when we talked about our drivers earlier this fiscal year, and I'm thinking it was probably going back to our December meeting where we presented the status quo rates. What we have seen in past years on the inpatient side is declining utilization but rising PMPM spend, which tells you that it is primarily unit costs, unit prices. But we have started to see over the course of the last year that inpatient medical utilization has actually also increased in addition to unit price increases. Lauren, you want to
Yeah, I can weigh in
correct me if I'm wrong or give some context?
Nope. So I can weigh in on, again, this is just a 1-year trend, but what we're seeing for inpatient medical and surgical in this graph are that the increases were mostly driven by increasing unit costs, which of course could point to price, but could also indicate higher acuity and a smaller increase in utilization, which in this case, we're counting inpatient days. So it's possible that there were fewer admissions, but greater, longer lengths of stay. But in this case, we saw increasing unit costs and a smaller also increase in utilization.
Thanks. Yeah, we should keep moving. Thank you.
All right, so I think we can move on to the next slide, please. Okay, so this is the GLP-1 graph we've shown previously with data updated through February 2025, showing monthly GIC paid amounts and monthly utilizers for non-Medicare on the left and Medicare on the right. The purple lines represent GLP-1s with a weight loss indication, and the yellow lines represent GLP-1s with a diabetes indication. In the left set of graphs, you can see that the purple line began rising pretty steeply around the beginning of calendar year 2024, and the increases in utilization and GIC paid dollars have been steady since then. The PMPM trend we looked at on the previous slide only captures about 6 months of this upswing, but it's clear from this graph and as we've been talking about that this class of drugs is a trend driver for fiscal 25 as well. As of February, there were about 11,000 non-Medicare utilizers of weight loss indicated GLP-1s, corresponding to a monthly GIC paid amount of $15 million pre-rebates. The GLP-1 drugs have a Tier 2 copay, meaning that non-Medicare members pay $30 out of pocket for a 30-day supply or $75 out of pocket for a 90-day mail order supply. In light of these trends, the GIC has launched a workstream exploring market solutions to reduce spending while maintaining access to these drugs. Next slide, please. Okay. And for our final objective, we'll take a look at how GIC member out-of-pocket costs compare to the rest of the Massachusetts market.
Lauren, before you go into this part of the presentation, Commissioner McEnany has a question. Would you be willing to address it here?
Sure.
Yeah. Go ahead, Eileen.
Thank you. I am just wondering, and maybe we can hold off, but for GLP-1 usage for weight loss, is there different criteria or is there like step therapies, right? Are people required to have diet and exercise under medical supervision or something? Could you just remind me how we treat access to GLP-1s for diabetes versus weight loss, or if it's the same?
Yes, there are different prior authorization criteria for the weight loss GLP-1 drugs compared to the diabetes GLP-1 drugs. Members are expected to use the drug in combination with a reduced calorie diet and increased physical activity, as well as have participated in a comprehensive weight management program for at least 6 months.
Thank you.
Do you, Lauren, I can't help asking, do you guys get the data from members in aggregate, obviously de-identified, on usage of the program, the comprehensive weight management program, to see, how does utilization, I'm guessing it's not 100% utilization, but is there any cutoff points where if a member is supposed to utilize a solution and they don't, do we cut them off from paying for their medications, or how does CVS deal with that?
I would probably have to follow up in order to answer the specific question around how many members continue that program. I know that we have received high-level prior authorization aggregate numbers from CVS in the past.
Yeah, no, that's great that they're approving them so that our members have access. But the usage on the program, the comprehensive weight loss program that is in combination, how often are they looking at the data every month to see if the member is utilizing the program? So another way to ask it is, what's the overall utilization every month in aggregate for our members for the comprehensive weight loss drug? And are there efforts that CVS is making to ensure that our members are using that program? Because I bet it's pretty comprehensive and useful for them, for their health. Yeah, so if you could follow up, that would be great. I think I'd love to see that.
Sure.
All right, let's keep moving.
Okay. Great. So here we're looking at this section of the report. We'll take a look at how GIC member out-of-pocket costs compare to the rest of the Massachusetts market. This graph here is showing the medical benefit levels of GIC non-Medicare plans. The benefit levels represent the percent of total medical costs covered by the GIC. So we can see that this percentage has been consistent over the past 3 years, landing at 91.6% in fiscal 24. We'll compare this to benchmarks from the fully insured Massachusetts market on the next slide. This is a graph from CHIA's most recent annual report showing the fully insured benefit levels, or again, the percent of medical costs covered by the plan by market sector for calendar year 2023. The most appropriate comparison for the GIC would be the blue bar all the way on the right-hand side for jumbo group employers with over 500 employees. The Massachusetts Jumbo Group plans covered 89% of medical costs, which is a little lower than, but in the neighborhood of the GIC's 91.6%. This means that the GIC's benefit designs are comparable to, but a bit more generous than the average fully insured Jumbo Group plan. Next slide, please. So this graph is also from CHIA's annual report, but here we're looking at out-of-pocket costs PMPM by market sector. While CHIA's methodology and time period differ from the metrics presented earlier in the report, we can see from the bottom blue bar that GIC plans have the lowest out-of-pocket costs of any employer-sponsored insurance market segment at $49 PMPM. Again, the closest comparison would be to Jumbo Group, which is the blue bar just above the GICs at $61 PMPM. There is a caveat to this data, which is that data for prescription drug carve-outs is not included. So the GIC's number does not include prescription drug out-of-pocket costs, and Jumbo Group plans likely vary as to whether prescription drug benefits are carved in or out. We still felt that this comparison was relevant since we're comparing within the Massachusetts market, and we know that Massachusetts tends to have higher costs for healthcare than other states. But just as a rough comparison, GIC out-of-pocket costs averaged just under $60 PMPM in fiscal 24. We can also see from the gray box on the right that CHIA reported a smaller 2023 increase for GIC at 2.7% compared to the 3.7% increase for Jumbo Group employees. Next slide, please. Finally, I wanted to highlight one more CHIA graph from the Massachusetts Employer Survey, which was fielded in the spring of 2024 and asked employers about the plans they offer and how they make decisions around health insurance. The dark blue bar in the top set of bars here shows that 31% of large employers with 200 or more employees increased member cost sharing in 2024 as a way to reduce employer costs. The GIC has thus far avoided shifting costs to members by continuing to offer plans with robust coverage, but this graph shows that market conditions are increasingly forcing plan sponsors to make difficult choices. This is why affordability is one of our top strategic priorities and is something we constantly evaluate when making decisions. Next slide, please. All right, we've made it to the key takeaways slide. So let's recap our findings for each of these objectives. First, we looked at member out-of-pocket cost trends in the context of GIC paid trends. We found that member out-of-pocket costs have been very stable with a slight decrease in fiscal 24 due to prescription drugs, but that GIC paid costs have risen as healthcare costs increase. Next, please. Fiscal year 24 was the first year of the new contracts post-procurement, and member migration complicated interpretation of the trends a bit, but we found some examples of how those procurement changes effectively reduce costs for both members and the GIC. Despite those savings, increasing costs across many medical service categories and rising utilization of GLP-1s drove the increases in GIC paid amounts. Next slide. And finally, we compared GIC member costs to the other plans in the state and found that GIC members have relatively low out-of-pocket costs and that recent increases have been relatively small. This finding is consistent with past reports. And this is my final slide, so I'll pause here for any questions or reflections from commissioners.
I don't see any. I certainly like the way you've retooled the report and kind of given us a flavor of how the procurement and member movement has impacted some of our costs. So, I think that's a really good job that you and the team have done. So I want to commend that.
Thank you, Chair Sullivan.
Yeah, and you can see Commissioner Edmonds is hard at work clapping on mute. Others as well.
Thank you.
I don't see anyone. I think you've been comprehensive in your approach and been very detail and data oriented. So I think it's good data. I think we need to see more of that and use that data, as I know you are, in figuring out what our budget needs to be next year, so we're not in our supplemental budget situation again. So we applaud that effort and appreciate the attention on this. So at this point, unless Matt, you want to make any final comments, we'll move to other business, right? We'll keep moving the agenda forward.
Yep, nothing further to add.
All right. Okay. Well, thank you. It's always a highlight of our calendar year or fiscal year meeting to have a report on out-of-pocket. So again, thank you for the retooling and the good information. So as a reminder, our next meeting is in June. It is on a Wednesday. I can't remember a recent time where our GIC meeting wasn't on a Thursday. So let's be sure to mark our calendars for June 18th for our next GIC meeting. I will take any kind of other business if there are things that we should be bringing up. So at this point, we can move on to the final slide if you have it.
It's like Anna has a question.
Sorry, I just had a question about the June meeting. I think last time we all got together, there was some discussion that we would be in person for June, and for planning and I mean, I think that would be great. How is that evolving?
Yeah, I mean, Anna, I'm a huge fan of getting the commissioners together in person. I know there have been some challenges with rooms, and I remain very hopeful that in the fall, either September or October, we'll be in person. But I will put that out there, have it in the notes, and try to be as persuasive as possible as chairman here to Matt and Erica and Emily and Andrew to start working on it now so that we can see each other in person, because it's always nice. And for a reminder, we said we could start at 9 or 9:30 so that the traffic isn't so insurmountable for those who have to come in from far away. It'll also be nice to meet our new commissioners face to face. Jason is relatively new. Gerzino, you're still relatively new to us, and now we have Kristen. So it's if that's a catalyst for staff, would love to have a pin in that. And Catherine, we saw Catherine at a recent event, so that checked the box for me, but Catherine's still relatively new too. So it's good to get together in person and exchange some Pitocin and other good feeling hormones by being in person. So thank you, Anna, for raising that. So at this point, I think we can, unless there's other discussion, I can give you almost 45 minutes back in your day. So if you want to go to that blue slide for other business or adjournment, or not, there we go. So at this point, I will entertain a motion to adjourn.
So moved.
And all in favor? Yeah, and first and second, all in favor? Aye.
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 Anyone opposed to the extra time? No. So at this point, we're adjourned. We'll see you next month on a Wednesday and appreciate all the hard work the GIC staff is doing for our members to get the supplemental budget across the line approved for today.